Thank you very much, Tess, for the invitation to speak today. I see there's a huge number of people on the call, and I'm very grateful for the opportunity. So I suppose I am the only person talking today about polycystic liver disease specifically. And I really want to start off by saying that we are, I think, very much behind our kidney colleagues generally in the liver field in terms of understanding the disease, understanding the burden, and perhaps most importantly of all is having effective treatments for this. But I think I would also be keen to say that this is an area of very active research, and I'm very hopeful that in a few years' time we'll be able to offer those of you who suffer from your liver hopefully medical therapies that can work as well as tolvaptan works in terms of the kidney and preventing cyst growth. So I'm going to focus on what we know, but perhaps more importantly, what we don't know as well. And here is an outline of my presentation. I don't want this necessarily to be totally a lecture. I want to leave plenty of time for questions. And as I said, there are a lot of knowns, but perhaps more unknowns. So there are different forms of polycystic liver disease. There are different kinds, if you like. And I've listed the forms here. Polycystic liver disease in its pure form is often called PLD. It's caused by different genes to those that cause cysts in the kidneys. And you only need one copy of the abnormal gene, and we call those diseases autosomal dominant. But there is also liver cysts that occur in the context of kidney cysts as part of autosomal dominant polycystic kidney disease, which I'm sure is, as I say, that the main focus of today. And in those, cysts occur in both the kidney and the liver, as well as in other areas. And liver cysts are said to occur in up to 94% of patients who have autosomal dominant polycystic kidney disease. And there are several genes that have been identified. But there are also liver cysts that occur in autosomal recessive polycystic kidney disease, where you need two abnormal copies of the genes. And I'm not going to spend a huge amount of time talking about the genetics, because I think you've had people talking about them already today. This is just a list from a publication last year of some of the genes that we know are associated with formation of cysts in the liver. And as you can see, there are a number of genes that have been identified. We still don't know necessarily what the proteins that those genes code for. If you like, genes give you the blueprint for producing proteins, and those proteins have function within your cells. And what we don't necessarily know yet is, especially for the polycystic liver disease genes, what those proteins do. And it's only when we really understand some of the abnormalities that these genetic changes cause that we can start to think about designing treatment that specifically, hopefully, prevents the growth of the liver cysts. But that is the current situation. And I think I'm probably not telling you anything you don't know, but everyone is unique in terms of the formation of their cysts. So here are three different patients. These are MRI scans, so magnet scans rather than CTs, which rely on X-rays. These rely on essentially a magnet to give you good pictures of what's going on inside the body. And if you can imagine, these are sections taken vertically through the body, so that what you are looking at effectively is someone, but deeper inside. So you're looking face on at someone and you're looking deeper inside. And I'm not sure whether you can see my cursor or not, but if we take the person A, you can see the liver is enlarged. Normally you would expect the liver not to be down at the bottom where your big pelvic bone in the bottom of your tummy is. But this liver is enlarged, but you can see the cysts are distributed very much on the outside of the liver and not in the middle of the liver. On the other hand,
Ahmed,
yes,
sorry to interrupt.
Yes, Jane, sorry.
Can you get either a little closer to your mic or increase the volume? We're having difficulty hearing you, particularly the translators. Thank you.
Apologies. Is that any better at all if I speak up a bit?
It's better for me.
Okay, hopefully it's better for the translators as well.
Thank you.
Tell me, can you see my cursor, just so I know whether I can use it or not?
Yes, we can see it.
Lovely, thank you. Right, technical difficulties aside now, right. So whereas if I move on to patient B, you can see here that the cysts are essentially distributed throughout both sides of the liver. They are quite small, some of these cysts, like these ones, and there's not much of the liver that's left that isn't involved in the cysts. And then this probably is the most severe case here, case C. And you can see that these are very big cysts. Some of these are probably 7 to 8 centimeters across. You can see they go a long way down into the pelvis. And you can see here that you can imagine that there's pressure on the lungs that will cause shortness of breath. The heart here is also compressed by some of these cysts. And you can see here's a kidney that is probably the right kidney that's been moved across because of the volume that the liver is taking up. So you can imagine this patient here, patient C, having quite a lot of symptoms from the cysts in the liver because the liver is so enlarged. So patients come in different sizes and shapes, cysts come in different sizes and shapes. And so we try and classify cystic disease in the liver into mild, advanced, and severe. And that's based on the number of cysts, the size of cysts, and how much of the liver is involved in these cysts. And here is a nice figure to show that as you progress, you do tend to get larger number of cysts, or the cysts can grow in size. But there are some important considerations, I think, that's worth making and worth highlighting between cysts in the kidneys and cysts in the liver. So you're all used to the idea that cysts in the kidneys result eventually in a reduction in kidney function, and you're all used to this concept of speaking about an eGFR, and that if your eGFR gets to a low enough stage, you need to go on dialysis. It's different in the liver. Cysts in the liver hardly ever cause what we call liver failure. So your liver is an amazing organ. It's the only organ that you can take away 2/3 of the liver, and the third that's left will grow back to the same weight and same function as the liver that you had originally. So the liver has an amazing ability to regenerate, to sort of repair itself. And that's part of the reason why you tend not to get liver failure with cysts, because what's left can expand and actually take over the function of a normal liver. And the liver does all sorts of different functions compared to the kidneys. It's involved in producing proteins. It's involved in essentially detoxifying things from essentially getting rid of the waste from your food. It's involved in metabolizing your medication. It's involved in lots of different things. Well, what the cysts do is, as I've shown you in the picture, they result in compression of important structures, such as the inferior vena cava, the big vein returning blood back to your heart, or the portal vein, which is the big vein draining blood from organs inside your tummy back up to the liver. And the liver is the only organ in the body that has both a vein and an artery going in and a vein going out. And that can result in particular complications that you may wish to ask me about in the questions. The other thing, similar to cysts in the kidneys, is that cysts in the livers can bleed and become infected. And that is often a difficult thing to manage because the blood supply to those cysts isn't as good as the blood supply to the normal liver. So sometimes people need lots of antibiotics to be given to manage cysts in the liver. And obviously when bleeding, it can cause significant pain. And I noticed that there's a session later on today about pain in cystic disease. And I think that's something that we as doctors underappreciate, that cystic bleeds can cause really, really bad pain in the liver. So how do we treat liver cysts? And as I've said at the beginning, I think compared to the kidney world, we're still far behind. So the first thing with liver disease cysts is, do they cause symptoms? And if the answer is yes, then we need to define what we're going to do about the symptoms. So can we stop the cysts getting bigger so that the symptoms that we've got now aren't going to get worse? Well, the answer is maybe and maybe not. And I'm going to come back to that and the medical treatments that we have available a bit later, because I think the data, the amount of information that we've got about the medical treatments is very, very limited. The other things that you can do are to intervene. And here are the things that you can do. So you can actually, especially if you've got one big cyst in the liver like this patient has, you can imagine very easily going through the ribs with a needle, sucking out the fluid out of that cyst and putting in something that causes that cyst to scar up. And hopefully that will reduce the amount of symptoms this patient has got. So this is called aspiration, as in sucking out the fluid, sclerotherapy, as in putting in something to cause the cyst to shrink up and shrivel up. In this patient here, in the middle, sorry, if you can, hopefully you can see my cursor, you can see that most of the cysts are on the surface of the liver. And you can imagine if a surgeon goes in with a keyhole instrument and they essentially do something called defenestration, so they remove the roof, this bit of these cysts, then the fluid can all leak out and you can cause, and you can allow the patient to feel better because these cysts shrivel up. Or finally, the other surgical option that we have is that you can see here, for example, that this patient, if I can get my cursor back up, has got cysts in the left side of their liver, but actually the right side looks reasonably okay. So you can imagine a surgeon going in and essentially resecting, cutting out this part of the liver, which may be the one causing all the symptoms, and leaving the relatively normal liver behind. The problem with all these surgical procedures is that you're not dealing with the other cysts left, and they often grow and replace and cause problems in the future. And you have the complications of different operations, which I'll come back to briefly. The only definite cure that we have right now is liver transplantation. And in a center like ours in Birmingham, where we do about 200 adult liver transplants a year, we probably do about 3 or 4 for polycystic liver disease. And those transplants are not because the liver is failing. Those transplants are mainly because of symptoms and people's quality of life. So I've talked about the type of intervention in surgery. And I think it's important to say that one solution doesn't fit everyone. And also it's important that the local expertise, the ability of the surgeons in the particular center where you are looked after comes into the equation. If a surgeon has done lots of these procedures, knows what they're doing, then they can have a reasonable conversation with you. And more importantly, hopefully the rate of complications after the operation will be significantly less. What you don't want is a surgeon who hasn't done many of these, or an interventional radiologist who hasn't done many of these, who may cause more problems by intervening than not by intervening. And also, it's important to think if this patient, is this patient likely to need a transplant in the future? And if so, by intervening with an operation, am I going to make the transplant in the future more difficult? Because any operation is associated with scar tissue. And if you cause scarring around the liver, then removing it at the time of a transplant becomes more difficult. So there are lots of things that we have to think about. And that's why decisions like these are really important to take place in what we call a multidisciplinary team environment. So it's not one person's decision. It's not just a surgeon. It's a physician. It's an X-ray doctor, and ideally a psychologist as well, and someone who manages nutrition as well. Because the other important consideration is the size of the liver cysts causing problems with that patient's nutrition? And I know you have a nutrition session after the break, after my presentation. So how successful is surgery? So as I mentioned, it can be very successful in some people, but often the success is temporary. And it's important to say that the cysts left in the liver continue to grow, as I've mentioned. And in one big study, it suggests that the complication rate after removal of part of that liver, so a resection, is up to 21% with a death rate of 2.7%. So these are not easy operations. The liver is a very, very blood-rich organ. And so therefore, any operations involving the liver have lots and lots of complications, including the fact that when you cut into the liver, you're cutting into the bile ducts that produce bile that help you digest, and you can get complications from that. So these procedures, as I say, are best done in centers used to operating on the liver. So how about the left-hand side of that diagram that I showed you? Can we prevent cysts from growing? Can we even go one step further and cause liver cysts to shrink? Well, the answer is we don't have the tools right now. So the main medical treatment that we do have currently is something called somatostatin analogs. Now, somatostatin is a hormone that is normally in your gut, and the analogs are, if you like, chemically, synthetically manufactured forms of a somatostatin that last longer, so we don't have to give them as often as you would have to give normal somatostatin. And the way they work is by reducing the amount of secretion into the cysts. So you can imagine if you have a cyst that's already there, established, and you give somatostatin, you're going to prevent the cyst getting bigger, but you won't necessarily cause it to shrink. And these analogs are given by injection once every 4 weeks. Now, the original trials looking at things like lanreotide only actually looked at the effect of being on it for 6 months to 3 years. We don't have longer term follow-up on some of these patients. And in fact, there are still trials ongoing. So some of you who live in places like Barcelona, I'll come back to this. There are trials that are looking at longer term on the applicability of these somatostatin analogs. But in some countries, they're not available. So even though I work in the UK, I cannot currently prescribe lanreotide or octreotide for polycystic liver disease because it is not available on our National Health Service. So if a patient is able to pay for it, they can, but I can't prescribe it as part of sort of the National Health Service that most of our patients access. And the other issue with some of these drugs is that they can cause side effects like tummy pain, pale stools, diarrhea, and they can result in the formation of gallstones within your gallbladder. So these aren't without side effects, some of these therapies. There are other medical treatments that have been suggested in small studies to potentially work. There's a medication called ursodeoxycholic acid, which is a treatment that we use a lot for other forms of liver disease. It's a synthetic bile acid. And there was a small study published by the group of Joost Drent, who is probably the world expert on polycystic liver disease from Holland, that showed that potentially it might halt liver cyst growth in autosomal dominant PKD patients, but not PLD patients. As I say, the follow-up was very short. The number of patients was very small. Personally, I've used it in a few patients. I haven't noticed that it improves their symptoms, but I haven't systematically looked at the size of their liver through imaging to see whether it's made a difference. Now, tolvaptan, which has been mentioned several times already today, is generally not thought to prevent liver cyst growth, as the receptors that tolvaptan targets aren't present in the liver. So the protein against which tolvaptan works isn't expressed on liver cysts. So it's not surprising that tolvaptan, although it might have an effect on kidney cysts, does not have an effect on liver cysts. So as I hope I've said to you, the options really are surgery, but only in a selected number of people, transplant, but really only when the symptoms are very severe, or we have some of the complications of compression by the liver of some of the important structures around, or if we have infections inside the liver that become very difficult to treat, or if people are really starting to struggle from a nutritional point of view. Those are sort of the things that we often use to decide whether a patient is eligible or whether we should offer the patient a transplant. And some people want it and some people don't. surgery, which is only really applicable in certain situations when people have certain patterns of cysts, and also when you have the local experience for surgeons to be able to manage it. But it isn't without its problems, as I've already mentioned. And in terms of medical treatments, I think we're still very, very limited in our ability to manage cysts in the liver using drug treatments. But I think it's important for us as physicians and doctors managing patients with cystic liver disease to acknowledge a few things. Having polycystic liver disease is horrible. It's horrible having polycystic kidney disease as well. The compression, the symptoms, the pain can be very difficult to manage. It can really significantly impact people's quality of life. And I think perhaps one of the worst things, especially my female patients often say to me is, I'm fed up of people saying to me, oh, you're pregnant then, or oh, when's the baby due, or them having to buy very loose fitting clothes to hide the size of their abdomen. And feeling bloated all the time and having a big abdomen is horrible. And it has all sorts of psychological consequences that I'm sure some of you living with this condition know only too well. And I think as healthcare professionals, we're often unaware of these. And we think, oh, but you know, this isn't going to kill you. Polycystic liver disease isn't going to kill you. Just get on with it. That's not the right attitude to have, I think. And I think many of us are ill-equipped to deal with it. And part of the problem is, as healthcare professionals, when we don't have a huge amount to offer, we often try and not sideline the patients. I don't think anyone wants to do that intentionally, but we often feel very, very frustrated, and therefore we try and belittle the symptoms. And I think that's something that we need to change moving forward. And that's where, as the previous speaker said, having the patient voice involved, having the patients advocating and saying, look, it's great that you're doing lots of research in the kidney field. How about the liver field? How about PLD? How about ADPKD? You've sorted out my kidneys. You may have done a nephrectomy. You've given me a transplant. My kidneys are not the issue. How about my liver? And I think that's really sort of important to have you guys really advocating for liver research in this field. And finally, I'd like to finish with a couple of things. First of all, there are lots and lots of unanswered questions in the liver cystic field. One is, what is the best timing of liver transplant in someone with combined cysts and a declining EGFR? Because when you do a liver transplant, you also reduce kidney function. And so sometimes those discussions of whether you do a liver and kidney at the same time, you do your kidney first and leave the liver until later, those are often very difficult discussions. What other medical treatments should be tried? What is the rate of growth of liver cysts? Does it differ between men and women? Anecdotally, we think it does, but we haven't got the data over time to definitely prove that. Is there a difference between pure polycystic liver disease and liver disease associated with polycystic kidney disease? Are there differences in the way they respond to treatment? And this is where I think we need a lot more research. So highlight a couple of things. There's a trial about to start called Against PLD, which is for female PLD patients, not ADPKD, but PLD patients, who are going to be treated with something called leuprorelin, which is a medication that inhibits production of all female hormones. So as you can see, this is a very small study, and it will be mainly in Belgium, in Holland, in Cologne in Germany, and in Barcelona. So those of you living in those areas who've got PLD, please ask your physicians about clinical trials. And we've got a UK registry, which is part of an international registry starting soon, which will hopefully enable us to look at issues and to look at data over the longer term in polycystic liver disease. And on that note, I thank you very much for your attention, and I'm happy to answer any questions.
Thank you, Ahmed, for that talk. As expected, we have had a lot of questions. Some of them are very specific, and in the interest of time, if I can ask, we can ask you those later, and then we'll get them translated and sent out in the summary. Sure. But we've had some just a couple of general questions. One is about estrogen, and those questions have been asked by women. So I wondered if you could address that topic.
Sure. So we do know that estrogen does increase the rate of cysts growth in liver disease. And we know that, for example, pregnancy can be associated with significant acceleration of cyst growth. And I certainly have a couple of patients who've had some major problems during their pregnancies because their liver cysts have grown significantly. The other difficulty is not that many obstetricians don't know how to manage patients with polycystic liver disease in terms of managing their pregnancy. Because you can imagine a big liver, add to which a big uterus, and you can start to imagine the symptom burden is going to be significantly high. So generally, I'd say to my polycystic liver disease patients to avoid taking the oral contraceptive pill, to think about other methods of contraception. There is some data suggesting that the number of pregnancies people have is associated with a higher number of polycystic liver disease. I would never dream of saying to a woman, don't get pregnant. I think we try and manage it the best way we can, but certainly taking extra hormones, I think it is to be avoided in female patients with cysts in the liver.
And is that, somebody had asked particularly about desogestrel? I'm not sure what type that is.
Yeah, I think it goes for all estrogens. So I don't think there's any evidence that, to my knowledge, that a particular estrogen is worse than another. So I say avoid all estrogens personally.
Mm-hmm. And I'll just allow one more final question. It was to do with a couple of people asked about infections, and somebody had asked if they're from the gut or the bloodstream, and also how best to treat them. But I realize that it could be a topic, a lecture in its own right. But
sure. So I mean, infections probably are originating from the gut. So what happens is that because your liver gets all the blood supply from your gut, there is an intricate connection between your gut and your liver, and you do get what we call translocation. So you can get bacteria going through the gut wall into the veins that drain the gut, and that the first place they go is towards the liver. So almost certainly the infections that you see in the liver are occurring because of blood flowing from your gut that's got bacteria from your gut going up into your liver. The other source in some people is that you can get what we call reflux. So from the gut up your bile duct into the liver. The treatment is antibiotics through the vein. And usually it needs 4 to 6 weeks to really get into the cysts. But we do have some patients who, despite giving 6 weeks of IV antibiotics, you think that they've got better, you discharge and they end up back in hospital in 2 weeks' time. And those ones that have really difficult to treat infections, that's often when we need to think about a transplant, because you're not going to get rid of that bacteria-laden environment without doing a liver transplant. And that's often the indication. But those are rare. There's a very small number of patients, but it can be a big problem.
Thank you for that. And thank you very much for joining us today, Ahmed. And
no problem. Pleasure.
I'll get back to you with those specific questions later after the event. Thank you.
Sure. No problem. Thank you.